Okay, good morning, all of you. We will be starting with the next session, which is the last rapid fire glaucoma update session. So we can probably begin so that we can finish on time. Maybe the first presenter, who is Yuanbo Liang, can probably come. Yuan Bound Lang, can please come. Okay, so Kevin, you are the next. You are the. We don't have the first speaker apparently. So maybe you can begin. Okay.
All right, we'll get started.
Yeah.
The previous session was a little too excited. We'll make sure we will catch up the time. So if you have any flight schedule, we'll make sure you can catch it too.
So I think the first now the talk will be given by Kevin, who is going to talk about explainable machine learning predicts intraocular pressure from demographics and physiometabolics in glaucoma patients.
All right, thank you. And I have no conflicts of interest to disclose. All right, so the main purpose of this study is related to predicting glaucoma treatment effect. As most of you know, glaucoma is a chronic neurodegenerative disease of the visual system, and current treatment is targeted at lowering intraocular pressure. But the IOP is not always effective after the medical treatments or surgical treatments. So we want to know if we can utilize explainable machine learning to provide a mechanism to individual prognostication and the identification of factors associated with the treatment outcome. In this study, we utilized the UK Biobank to obtain information from 290 eyes from 161 participants. These patients have undergone baseline assessments with a reported diagnosis of glaucoma, and they were also receiving treatment. We tried to group the features into three distinct data sets. One is the demographic data only with 14 features. The second one is the physiometabolic parameters and medication prescription data, which had 28 features. And the third one is to combine all the data together for the prediction of the eye pressure in the second visit. We applied 5 machine learning techniques with a nested 3x3 fold cross-validation to each of the feature sets and combine the ability to predict the eye pressure at a follow-up visit, which is usually 2 to 3 years later in a classification task. High pressure will be 21 millimeter mercury or above, and then normal tension will be below this level. To do that and evaluate the importance, we use explainable machine learning algorithms called the SHAPE, additive explanation values, which is based on a game theory for assessing the feature importance for the best performing model, and we determine the feature importance and variability in the feature importance as well. So in terms of the brief results, here you can see there are 5 different bars for the 3 groupings of the feature sets. The 5 bars correspond to 5 different machine learning algorithms. The one is the LGBM, light gradient boosting machine, and then XGBoost, extreme gradient boosting, and then a support vector machine, random forest decision tree model, and then a linear logistic regression model. You may notice that for the 5 machine learning methods, the combined methods for the XGBoost will have the best performance, and the area under receiving operating curve is about 0.7. And when we try to rank what factors may be the most important among these feature extractions in predicting IOP outcome, we notice that the top 3 ranks constitute to the insulin-like growth factor 1, lymphocyte counts, and also the low density lipoproteins in terms of predicting eye pressure in the second visit after treatment. And then we also want to understand if there's any variation in the stability. So we plot the shape value variability for the maximum cross-validation and versus the minimum cross-validation set. And you can see for the LDL and the IGF-1, they have relatively low variability and densely distributed, suggesting that this model may learn stable statistical relationship between the features and the intraocular pressure outcome. So in summary, we used the explainable machine learning on the UK Biobank data, and we found that there is potential importance of the blood IGF-1, the low density lipoprotein, and also the lymphocytes in contributing to the outcomes of the IOP lowering treatment in glaucoma patients. And we also demonstrate among the 5 machine learning models, XGBoost seems to predict the outcomes with the best accuracy. And these findings may help to unveil the underpinning of glaucoma pathogenesis and therapeutic efficacies by identifying the factors and the interactions that may be involved in glaucoma, and especially whether these factors may be driving the eye pressure lowering treatment outcomes. With that, I would like to thank all our lab members from the Neuroimaging and Visual Science Laboratory, our collaborators at New York University, Wales Eyes, Duke University, Pittsburgh and Hong Kong, and also all the funding support. And thank you for your attention.
Thanks. That was a very nice study. Any questions from the audience? I think we can take some questions, yeah. I have a question regarding the fact that I think the numbers in such metabolic studies require to be very huge, because primarily you're looking at huge populations to actually come to a conclusion. So are you in future planning a larger study where you can actually pinpoint which factors could be more important?
Absolutely. This is just an initial screening, and even with the UK Biobank that has 500,000 data, there are very few subjects who have undergone both the baseline and the follow-up study with eye pressure and the blood sampling. So this is just an initial sampling from the already large population. But in the future, we do want to have either independent sample or from other populations to see if all these can be replicated.
And the treatment that you talked about was mainly medical treatment, or did it also include?
That's right. So for the treatments, there are 5 groups of medical prescriptions. If I remember correctly, those are the typical, the prostaglandin, the carbonic anhydrate carbonates, and then the cholinergic system treatments, beta blocker, and one more. So yes, among them, we look for those who have existing data as well for the 2 groups of sampling. Yeah.
Thank you.
Yep.
Yeah.
Yep. So when you say a multi-point, you mean multiple time points, right? So yep, that's right now we're using the baseline visit, so-called, in the UK Biobank. In UK Biobank, we call it instance 0. And then there's 2 time points called instance 1 or the instance 2 in UK Biobank. Instance 1 is usually 2 to 3 years after the first visit, and then instance 2 is usually 5 years or longer. So at this moment, we are looking into the first 2. That means instance 0, instance 1, separated by 2 to 3 years. Yeah. So this database is constantly uploading and updating from time to time. So there's also potential we could expand the population further. Yeah.
Thank you, Kevin. We'll have the next speaker, Dr. Minyu Ozaki, who will be speaking on cholesterol ester concentrations in the aqueous humor of patients with exfoliation syndrome.
Okay, thank you. So the genetics of exfoliation syndrome partnership performed whole exome sequencing on 8,000 patients with XFS and 12,000 controls. The analysis revealed a significant association between rare variants in the CYP39A1 gene and XFS. Japanese XFS patients with the CYP39A1 G204E variant demonstrated higher prevalence of exfoliation glaucoma compared to exfoliation syndrome patients without any CYP39A1 mutation. Odds ratio 5.1, and greater glaucoma severity and higher risk of blindness. Odds ratio 7.1. Pathological findings of exfoliation material in the ciliary epithelium of XFS patients with rare CYP39A1 variants demonstrated co-localization of esterified cholesterol, LOXIL-1, apolipoprotein E within exfoliation material. Dysfunction of CYP39A1 leads to dysregulation of lipid homeostasis in the cell, resulting in abnormal cholesterol metabolisms. This results in excessive accumulation of cholesterol esters in extracellular fibril aggregates. Our aim was to investigate cholesterol ester CE levels in the AIOS humor of XFS/XFG patients. From June 2021 to June 2022, AIOS humor samples were collected during cataract surgery from 79 XFS patients with 92 controls at Ozaki Eye Hospital. An optimized LC-MC workflow was developed for CE detection and quantification. UPLC-MS Analytica workflow for the relative quantification of cholesterol ester. Overall, an increasing trend in CE levels was observed in the XFS/XFG. An attempt this is a workflow for absolute quantification of CE. To reduce intra-group variability, two alternative approaches were employed. Include only samples with CE levels within the quantification range between lower limit of quantification and upper limit of quantification. Estimate CE levels outside the quantification range by replacing them with the values of LLOQ or ULOQ. In the AIOS humor of the XFS/XFG group, 6 types of CE were significantly elevated compared to the normal group. Systemic hyperlipidemia was not associated with CE concentrations in the AIOS humor. CE levels in the AIOS humor were higher in XFG patients than in XFS patients. In summary, cholesterol ester levels in the AIOS humor of XFS/XFG patients were significantly elevated compared to normal controls. The increased CE may be involved in the formation of exfoliation material. CE levels in the AIOS humor were higher in XFG patients than in XFS patients. We would like to express our gratitude to all our collaborators. Thank you so much.
Any questions from the audience?
So thanks for the nice topic. And I wonder, among the 6 cholesterol esters that you found significantly increased, do you have any insights? Which of them may be the driving factors in the formation of these exfoliation materials, or could it be an interaction of the six?
We are not yet analyzed the precise discrimination of the 6 species, but the cholesterol abnormalities may lead to blood ACAS barrier dysfunction, then protein leak, and also the cholesterol esters will be a kind of a sticky material to have a Loxil-1 or something inside to make exfoliation materials in the ACAS humor.
What do you think is the clinical implication of these findings? I mean, when you see increased cholesterol in the aqueous humor, how can you use it clinically in future?
Right. So thank you for the question. So if in the theory, so we'd like to block the abnormal homeostasis of the cholesterol using some drugs to prevent or suppress the progression of the exfoliation glaucoma or the onset of exfoliation glaucoma in XFS patients.
Yeah, okay. Thank you so much.
Thank
Yeah.
you. Okay.
Next. Thank you.
Thank you so
very
much.
much. And our next speaker will be Dr.
Anil.
Anil Parajuli. Is Anil here? Oh.
Anil?
Yep.
This side.
This side, please, yes. And he'll be talking about severity of glaucoma and factors affecting it, at first presentation in tertiary eye hospital in Nepal.
Hello everyone, good morning. Today I'll be talking on my research titled Severity of Glaucoma and Factors Affecting It at First Presentation in a Hospital in Nepal. So I have no conflict of interest, and well, as we all know, glaucoma is one of the leading causes of irreversible blindness worldwide, including Nepal. So the survey of Nepal shows that glaucoma is the 4th leading cause of blindness, and there are 2 population-based studies in Nepal showing that the blindness related to glaucoma is pretty much high in Nepal. So as we all know, later presentation is a considerable risk factor for glaucoma-related blindness, and the economic burden imposed by glaucoma increases as the disease worsens. So however, it's quite unknown thing why some patients present early while some patients are present with advanced disease. So the objective was to determine the severity of glaucoma at diagnosis and to identify the factors associated with the severity at presentation. So this was a hospital-based prospective study at Himalaya Hospital in Pokhara, Nepal. So we included only patients diagnosed with POSG from January 2023 to December 2023. So we included the demography of the patients with medical and ocular history, along with the awareness of glaucoma at presentation and other baseline data. So severity of glaucoma was quantified by various standard methods, and we kept patients into 2 groups, group 1 early to moderate and group 2 as severe. So we included only patients that were diagnosed with glaucoma for the first time during the study period, and if in case of bilateral involvement, the eye with worse mean deviation was included, and patients with prior diagnosis were excluded with ocular hypertension and glaucoma suspect 2 were excluded, whereas anyone with history of intraocular surgery except uneventful cataract surgery and those with corneal opacity, retinal diseases, uveitis, and neurologic pathologies were excluded. So the outcome measures were severity of glaucoma at the time of diagnosis and factors associated with severe glaucoma. So various statistical tools were analyzed, and the results were 173 eyes of 173 patients were in the study. So group 1, there were 86 eyes of 86 patients, and in group 2, there were 87 eyes of 87 patients. So when comparing between the 2 groups, when comparing the baseline demographic and clinical features, we found that patients who were more older were in the group 2. Likewise, in group 2, there were more males. And similarly, in the group 2, there were more patients with a higher IOP and thinner CCT. And the other thing was, those patients who took more time to reach to their nearest eye care center tended to have severe glaucoma at the time of presentation. So We did a binary multiple logistic regression analysis to know which factors were associated with severe disease. So we found that older age patients had the higher odds of having severe disease. Likewise, those with higher IOP at presentation had higher odds of severe disease. Likewise, those with thinner cystity had higher odds of having severe disease. Whereas one typical finding was that those who had systemic hypertension tend to present earlier in the course of disease. So as we see, majority of our patients had severe glaucoma at presentation, which is similar to many other countries like India, Iran, and Tanzania. So we can see that glaucoma is still undiagnosed. So moving on to discussion, comparing our study finding with other studies, we can see that, older age patients usually present late. Our study found that gender had nothing to do with the severity of the presentation, whereas several studies have found that male is a risk factor. So, like our other studies, our study also showed that higher IOP at presentation and thinner cystity had led to severe disease at presentation. Our study had no association with severity and family history, whereas other studies also have the same association. So we found that awareness had nothing to do with association of severity, whereas there are studies that show awareness decreases late presentation. Our studies show that hypertensive patient presented earlier in the disease course, whereas this finding is quite elusive in different studies. So diabetes had nothing to do with the severity. However, many studies show that this is a quite inconsistent finding. Our study found that travel time had no effect on severity, whereas many studies show that rural dwellers usually present late in the disease course. So moving on to the limitations, this is the hospital-based study and use of a single question to assess the patient's awareness regarding glaucoma. So moving on to conclusion, majority of the patients had severe glaucoma at the time of diagnosis, and late presentation was linked with older age, elevated IOP, and thin cystity, whereas patients with history of systemic blood pressure presented earlier in the disease course. So these are my references. So thank you very much for your attention.
Thank you.
Any questions from the audience? You want to ask?
So I'm just curious, when you show that patients with hypertension tends to present earlier in your hospital, at the same time in one of your slides you try to group the subjects into mild to moderate, and then there's another group of severe. These two groups actually did not have apparent difference in the blood pressure. So do you know, could you speculate why people with hypertension tends to be coming earlier? Is this anything related to glaucoma, or they just feel not good, or what was maybe the possible reasons?
Usually when I went through the literature, there was some conflicting findings about hypertensive and diabetics. Well, most of the patients with diabetics and hypertensive are usually referred by the physicians to the hospital to check for whether they have any hypertensive retinopathy or diabetic retinopathy. So that might be one of the causes why patients with hypertensive and diabetes might present earlier to us. And the other thing regarding hypertension is that hypertension usually follows a U-shaped relationship with the optic neuropathy, because as long as there is no arteriolitis, the ocular perfusion pressure is actually increased with the help of systemic hypertension. So it is kind of protective against high IOP to increase the amount of ocular perfusion pressure to the optic nerve head. So that might be the reason.
Right, thank you.
Okay, thank you.
I also have a question. I mean, what percentage of your patients actually were categorized as severe glaucoma? Like, what was the percentage? 20%, 50%?
It was 51 or 52. I saw it was just
Almost
87.
half of your patients
87 were severe.
presented with a very severe kind of glaucoma.
Yeah, out of 173, 87 were severe, and
Very
86 were early and moderate. So just by one, it was higher in the severe. So majority were
Huge amounts,
severe. Yeah.
Thank you.
Okay.
Thanks.
Thank you.
Any other questions? If not, then let's move on. You want to move on?
We have Dr. Rucha Hacha,
Good morning, everyone. I'll present a paper on steroid response in fellow eyes of glaucoma patient post phacoemulsification. As we all know, we use steroids most commonly, and they have many side effects. So the inclusion criteria were patient diagnosis POAG and PACG on glaucoma medications to target IOP who underwent uncomplicated phacoemulsification surgery, and age group was 40 to 80 years. Control was same age group with on non-glaucoma patients who underwent uncomplicated phacoemulsification. Exclusion criteria were secondary glaucoma patient, glaucoma suspect, prior filtration surgery, and complicated cataracts. A case control study of 103 consecutive adult glaucoma patients was done. They were all on target IOP, topical medication to target IOP, and completed 3 months follow-up for the uncomplicated phacoemulsification. 55 patients were taken as controls, and they were non-glaucoma patients undergoing uncomplicated phacoemulsification surgery. Informed consent was taken. Detailed history was taken. Preoperative examination was done, and same postoperative examination was done. Operated eye was started on prednisolone 1% eye drops 6 times a day with a tapering every 7 days for 6 weeks, antibiotic eye drops and NSAIDs eye drops in the operated eye. All the glaucoma medication were continued as preoperatively in both eyes in glaucoma group. After post-operative, the IOP measurement was done on day 1, 7, 1 month and 3 months in both the groups. So here are the comparison of IOP between glaucomatous and non-glaucomatous patient. So here we can see that there is no significant change in IOP preoperatively between two groups, but statistically significant difference post-operatively in IOP in the glaucomatous group, which range from 14 millimeters to 19 millimeters, whereas there is no significant difference in non-glaucomatous group. Here. Comparison of IOP between the difference of IOP was 5 millimeters of mercury in glaucomatous patient at the end of 3 months. So here we can see that it is a significant at the end of 3 months, while just 1 millimeter in non-glaucomatous patient. So more than 4 millimeter change, we can see 52% patient of glaucoma showed a IOP change of more than 4 millimeters at the end of 3 months, while just 3% of non-glaucoma patients showed more than 4 millimeters rise. 9.71% of glaucoma patients showed a more than 8 millimeter rise in IOP by 3 months, while not a single non-glaucomatous patient showed an IOP rise above 8 millimeters of mercury. So 66%, the age association we can see 41 to 50 years is the maximum age group, followed by 61 to 70 years. 54% of POAG and PACG, almost similar incidence was seen. Patient with moderate glaucoma, -6 decibel to -12 decibels showed statistically significant rise by end of 3 months. 50% were males and females. There was no significant difference. So here we know that the IOP above 21 millimeters to 24 or an increase of greater than 5 to 10 millimeters compared to baseline is called a steroid responder. So we know the definition of moderate responders, high responders and non-responders. So here, those with glaucoma have an increased risk of steroid response. It is illustrated in Becker and Mills study, in which the mean IOP elevation of those with glaucoma was 70 millimeters of mercury, compared with 4 millimeters of mercury in the control group. And upon cessation of steroids, the IOP usually normalizes within 1 to 4 weeks. Similar study, Boykin et al. Also showed that glaucoma patients were 3.72 times, like 4 times more likely to have steroid response after uneventful cataract surgery. So IOP is a risk factor for glaucoma progression. High mean IOP, intervisit fluctuation of more than 3 millimeters of mercury, and diurnal fluctuation. All this leads to a progression. Similar studies, Lee et al. Showed. Also, Metlach et al. Showed that short-term fluctuation and maximum IOP are a risk factor for progression of glaucoma on visual fields. IOP fluctuation was noted as a progression factor in Kim and Caproli study. So here we can see the graphs of stable eyes when the progressing eye shows very much fluctuation of the IOP. So to conclude, IOP fluctuation of 3 to 4 millimeters are thought to contribute to progression in glaucomatous eyes. Irregular and large IOP fluctuation may lead may cause loading and offloading of the stresses and which is unable to compensate, allowing the further damage. So glaucoma patient undergoing phacoemulsification have a frequent and significant rise of IOP in the other eye, in the fellow eye. So we must be carefully reviewed over a possible significant steroid response in the other eye, and its appropriate management should be done. Thank you. These are my references. Yes, ma'am. They were on medication. Yes, ma'am. Medication. Yes, medications were continued. Still, there was a rise in pressure. Ma'am, we took all the groups, mild, moderate, and severe, but moderate glaucoma groups had higher rise of IOP than the milder ones.
I was also wondering, the non-glaucomatous group, which was
Yes.
normal,
Yes.
they also had a rise of intraocular pressure. So do you clinically advise measuring intraocular pressure routinely for patients in the contralateral eye who are non-glaucomatous? I mean, would you advise it? I'm asking you.
Yes, yes. So definitely both the eyes should be evaluated post-operatively for a steroid response, because steroid response can be in a normal population, but it is much higher in glaucoma population. So we should monitor both the eyes.
How did you measure the IOP?
With applanation tonometry, ma'am.
Control as well as for
Yes, ma'am. Yes, ma'am.
inclination for the
Other eye. Yes, ma'am. Not the operated eye. We took the other eye. Yes, ma'am.
And can you briefly elaborate why the non-glaucomatous fellow eyes would increase only transiently for 1 to 4 weeks and it would drop in your data at 3 months?
It won't fall at 3 months after cessation of steroids. So it will come back to normal within 4 to 6 weeks. So, but we have to measure and we have to keep monitoring. If there is no reduction in IOP, we should add medication, or we can take a measure to reduce the IOP.
was the frequency of steroids the same for each of the
Ma'am, it was normal tapering dose 6 times a day on the second poster, first poster. Sorry, ma'am. Ma'am, prednisolone acetate 1%.
Okay, thank you. Thanks so
Thank you.
much.
Thank you.
Next.
Okay. All right, next speaker will be Dr. Nadezhda Gobunova. And should we talk about the possibility of implantation of an intraocular lens with extended depth of focus in patients with advanced glaucoma?
Good afternoon, dear colleagues. Thank you for invitation. In the era of active use of smartphones and other gadgets, patients increasingly want to have high visual acuity both distant and near. Currently, the most widely used method for correcting pseudophakic presbyopia is the implantation of a multifocal IOL or an extended depth of focus IOL, after which most patients do not need spectacles or lenses for vision correction at various distances. Naturally, the question arises, are the patients with glaucoma eligible for these IOLs? Currently, there are publications showed at non-diffractive IOLs. Это не та презентация, It isn't a presentation, right presentation. I choose today presentation. Please, it's possible to change?
Okay, yeah. So maybe we can have the next speaker and you can change it after this. Yeah, okay,
It isn't
thank
my
you.
presentation now.
Okay, it's all right. Maybe we'll have the next speaker, who is Lizen Guillemzonova. Yeah, presenting glaucoma in the Urals regional prevalence variations.
Good day, dear colleagues. Thank you for the opportunity to take part in the conference. And now let me introduce my presentation. This is my financial conclusion. And glaucoma is a socially significant disease, which, as you can see on the slide, is growing every year. It is known that the worldwide prevalence of glaucoma is 3.5%. There is lack of data in Russian Federation. To assess the prevalence and associated factors of glaucoma in the Russian population, we conducted the population-based Ural eye and medical study in typical ethnically mixed region in South Urals. So the population-based Ural eye and medical study include about 6,000 individuals. Mean age was 59 years. And our research consisted of 3 stages. The first stage was an interview, the second stage, a medical examination, and third stage was standard ophthalmological examination, and of course, different special ophthalmological examinations. And so our results. The proportion of men in the subpopulation of individuals with glaucoma was 44.6%, women 55.4%. A regular decrease in the frequency of each stage was noted depending on the severity of the process. The relative share of each stage is presented in the form of circular diagram on the slide. And the prevalence of glaucoma in different age groups of the population studied varied significantly. There was a tendency for the prevalence of this pathology to increase with age. In this regard, a relatively high percentage of eyes with glaucomatous changes in the optic disc was noted in all the age categories. So the highest intraocular pressure glaucomatous change was in group 18.5 to 89 age, 24.2%. There was a significant difference in the level of intraocular pressure between the subpopulation without glaucoma and with this pathology, with the greatest prevalence of this indicator in stage 4, IOP up to 21. The prevalence of open-angle glaucoma in the studied population was noted in 3.2% of cases and closed angle in 1.2% of cases. So the prevalence of open-angle glaucoma increased from 0.6% in the age group 14 to 45 years to 14 in the age group 18 years and older. And the prevalence of closed-angle glaucoma increased from 0 in the age group 14 to 45 years to 6.1% in the age group 18 years and older. It is interesting that among 246 respondents with glaucoma, only 32.5% were on anti-glaucoma therapy. Multivariate logistic regression analysis showed a correlation of glaucoma with older age, narrow anterior chamber angle, and higher IOP values, and thin arm fail. You can see on the slide our results. So we also analyzed the prevalence of blindness and vision impairment due to glaucoma. The appropriate level of visual impairment for study participants was determined using the World Health Organization classification. For ease of further data analysis, respondents with moderate and severe visual impairment were combined. The population-based Ural eye and medical study showed the number of people living in the South Urals with moderate severe visual impairment due to glaucoma is higher than the other world regions. The proportion of people blinded by glaucoma in South Urals is close to that in Latin America and the Caribbean. Higher than in the countries of South, Southeast, and East Asia and Oceania, and lower than the high-income countries, North Africa and the Middle East. Conclusion, the prevalence of glaucoma in our region was 4.4%, The prevalence of glaucoma in different age groups of the population studied varied significantly, with a tendency for it to increase with age. 2/3 of glaucoma patients were not on anti-glaucoma therapy, and the proportion of people suffering from moderate and significant vision loss due to glaucoma was 4.9%, and unfortunately blindness to the glaucoma was detected in 9.1% of respondents. Thank you for attention, and we invite you to take part in our annual international conference on ophthalmology in Ufa. Thank you.
Thank you, Leizan. Any questions? I was just wondering, when you talk of blindness, was it unilateral blindness or was it bilateral blindness?
Blindness very high in our region.
The
but
blindness wasn't in one eye, or you took blindness for both eyes?
One eyes.
Okay.
One eye.
So, yeah,
Yeah.
okay.
And its questions is interested our team, and I think it requires further research.
And what was the most common cause of glaucoma in your population? Was it a primary glaucomas or secondary glaucomas?
Only primary glaucoma.
Were the most
We don't include the secondary glaucoma.
Okay. Thank you so much.
Thank you.
Dr. Gobanova, I think she's ready for her presentation. Can we please switch back to her PowerPoint, the updated one, please?
Yes, thank you. Once more, good afternoon. In the era of active use of smartphones and other gadgets, patients increasingly want to have high visual acuity, both distance and near. Currently, the most widely used method for correcting pseudophakic presbyopia is the implantation of multifocal IOL or an extended depth of focus IOL, after which most patients do not need spectacles or lenses for vision correction at various distances. Naturally, the question arises, are patients with glaucoma eligible for these IOLs? Currently, there are publications showed that a non-diffractive wavefront shaping ADOF IOL can be safely implanted in eyes with early glaucoma. Purpose of our study is to evaluate the possibility of using an IOL with rotational asymmetric optics in patients with advanced glaucoma. The inclusion criteria were advanced stage of glaucoma with compensated intraocular pressure, cataracts of secondary stage, and the exclusion criteria were progression of glaucoma optic neuropathy, lens subluxation, retinal pathology, and lack of central fixation. In our study, we implanted the Lentis Comfort extended depth of focus IOL. The optical design of this IOL is based on the principle of rotational asymmetry with a sector shaped at zone of plus 1.5 dioptries in the lower half. In the control group of our study, we implanted monofocal IOLs. The study groups were comparable with regards to preoperative visual acuity, IOP, and glaucoma details. Additionally, the patients underwent visual acuity testing at an intermediate and near distances, computer perimetry with photosensitivity analysis, and assessment of vision quality using the questionnaire VF14. In both groups, we noted an improvement uncorrected and best corrected visual acuity in far distance. However, the Lentis Comfort group patients had higher uncorrected near and intermediate visual acuity scores compared to monofocal IOL group. In addition, IOP control was good in both groups. We also observed an improvement in retinal light sensitivity based on Humphrey field analyzer in both groups as a result of optical media clearance. We assessed the quality of vision using the VF14 questionnaire with 4 additional questions. The questionnaire included 5 questions for near and intermediate distances, 4 for far distance, and 1 satisfaction question. Total points are shown as a percentage. The lentis comfort IOL has a higher percentage at near distance compared to monofocal IOL. Also, lentis comfort IOL has a higher percentage at intermediate distance compared to the monofocal IOL. In both groups, the values are almost the same at far distance. Total points on all questions is the main group are higher compared to control group. In conclusion, implantation of an IOL with rotationally asymmetric optics increases visual acuity in near and intermediate distance. The retinal photosensitivity parameters, according to computer perimetry data after implantation of an IOL with rotationally asymmetric optics, were comparable with the data after implantation monofocal IOL. According to this review, the patients with main group were more satisfied with the quality of vision compared to the control group. Implantation of an IOL with rotationally symmetric optics can be used effectively and safely in patients with advanced glaucoma. The approach of choosing of type of IOL should be strictly individual. Thank you for your time.
Thank you.
Thank you very much. Any questions? So thank you for a nice talk. I'm just curious, since you have 2 major groups of patients of open-angle glaucoma and also the angle kosher glaucoma among your intraocular lenses, do you see any differences in the effect between the 2 groups?
In our study, we include open angle and close angle glaucoma.
That's right. So among the open angle glaucomas, were the responses, the visual acuity change any? Do they show any differences compared to the angle kosher?
No.
Okay.
The difference only in stage, maybe the
In stage.
first or the second or the third.
Okay.
Mhm.
Thank
Great.
you.
Thank you.
So we'll have next recorded presentation. This presentation is by Dr. Michael Coote on the rationale and results of a new resisting and distributing glaucoma drainage device.
Welcome, and I'm sorry not to be with you in person. Unfortunately, I've had to leave early. I'm Michael Coote, I'm from Australia, and there's a group of people on the screen who've helped contribute to this, including Surinder, who's from Chandigarh. We have been hard at work developing a new implant, and I'm going to present to you some of the rationale and the results of it. But I want to thank the other co-inventors, and as a moment of disclosure, I'm a co-inventor and shareholder in this process. As the light on the hill, the first point to make is that glaucoma surgeons aiming to get 2 microlitres a minute of fluid out of the eye, aqueous out of the eye at 10 millimetres of mercury. And that is something that is an engineering fact. Glaucoma surgeons face a lot of problems in this. There's encystments, bad blebs, leaking, erosion, endothelial loss, multiple post-operative visits, and of course failure, which is significant for both trabeculectomies and tubes. We'd obviously like to rid ourselves of all of these things, but we can't directly engineer away failure. What we have to do is understand why it occurs. And that process is digging into the mechanisms of failure, which include the loss of porosity of tissue, erosions, obstructions, inflammation, loss of endothelial cells, and the mechanisms that underlie that. Now, that's too much for this talk, but suffice to say what we ended up is a prototype implant which we tried in rabbits, which evolved then into the first human implant, which is VW50, and now you see a VW51 in front of you, which is slightly narrower. There are components of it that I'll draw your attention to. There's the tip, which has the flanges around it, which allow it to become water sealed through the cornea. This whole implant is only 0.2 of a millimetre high. It is curved around the surface of the eye. It has two collecting channels, or distribution channels, I should say, that go down to the hub more posteriorly, so that there is preferential flow of aqueous into the tissue quite posterior in the intermuscular space. The whole implant is around 20 millimetres long, but as only 0.2 millimetres high. There is two studies that I'll draw your attention to. One is a feasibility study which has completed. There were 10 participants that had mitomycin and potentially cataract surgery, but did not have any scleral graft, I should say. The pivotal study, which does not have cataract surgery, again involves mitomycin, does involve a scleral graft because there were erosions in the first study. We do think we can probably avoid erosions even without scleral grafts, but at the moment that's part of the study protocol. So I'm going to draw your attention to the first slide here, which is of the results of our feasibility study and SAS eyes. This means that eyes that had glaucoma were implanted, but not within the study, and using the same implant and the same protocol. Those 25 eyes that have reached 12 months, there's 18 months, 13, and 24 months, just 11 at this stage. There's a pretty tight pressure spread. There are no great surprises. The dotted lines around the sides are the highest and lowest pressures that any patient expressed during the study. So the first engineering feat was to get a predictable day one pressure, to avoid hypotony, to avoid anxiety in the surgeon, to avoid reduction in vision in the patient, to avoid secondary aqueous and inflammation and soft eyes and all sorts of things that run with that. So we dealt with that using a calibrated form of resistance within the implant, and that is a tricky moment, as you need to get the difference between not too much resistance, which leads to a lot higher end pressures, and not enough to avoid the hypotony. We also need to make sure that all the fluid leaving the eye goes through the implant, so there can't be any leak around the outside of the tip of the implant. And so these two design features, which were part of the user needs analysis, ended up, of course, in the implant. Now, we've got a very tight day one spread of pressures. We've got only 8% numeric hypotony and no clinical hypotony. So broadly, we're comfortable with that as a solution. Predictable long-term pressure and avoiding failure really is around protecting the bleb. Part of that is around having a wide distribution area, protecting the tissue from hydraulic stress, and having this posterior presentation of fluid more than anterior, which is much more robust in the long term. We've had no reoperations for intraocular pressure elevation. We have an 89 or 90% reduction in medication usage, and in the first study there was a 16% anti-metabolite injection, although that's significantly reduced to almost zero in the second study. Avoiding device blockage occurred because of multiple channels of egress. There's over 150 points of egress, and the lumen of the tip entering the anterior chamber is flanged so that it doesn't get captured by iris. It's also got a wider lumen than just its tip, and it's been designed so that it will not, even if it flexes, it won't obstruct. We have, to protect the corneal endothelium, anything that enters the anterior chamber has got a risk of losing endothelial cells, and we're all aware of previous implants that have had catastrophic effects on endothelial cell function. We reasoned that the reason that there was a loss of endothelial cells over time is movement of the cannula. There is positional issues if it's more anterior, and of course size and the amount of sort of flexing and inflammation that's involved in them. In essence, this is now a very short anterior chamber portion. It's relatively posterior, it can be pressed almost against the iris, and it's very narrow. This is a 27 gauge entrance, and the tip even smaller than that. There's no loss of endothelial cells over the first study, and we're not seeing any of that in the second either. Erosion was an issue with the first study. Part of it was because we thought the implant was a bit oversized and it buckled a little bit side to side. We've now redesigned that, and it's narrower, and we're not having any modifications. Further, the scleral graft is used to make that bulletproof, but there are certainly no subsequent erosions. Patient comfort is very high. There is no anterior bleb, there's no Dellin formation, there's no rotation, there's no filamentary formation, and there's early predictable intraocular pressure, so there's very good visual recovery. And finally, we can see that there's not a lot of unpredictable behaviour of the implant, so hopefully the burden of care and the inefficiencies of managing trabeculectomies, which is enormously burdensome on healthcare systems, should be reduced. Many thanks for your attention. It's 10 years more of work compressed into 7 minutes. Bye-bye.
Great. I don't think Michael is here for questions, so we'll go on to the next talk, which is on age-related effects of optineurin deficiency in the mouse eye by Kevin Chan.
Hi again. So this study is in collaboration with Dr. Henry Sen from Duke University, and we wanted to understand if optineurin may play any roles in glaucoma, especially normal tension glaucoma. And again, we have no financial conflicts to disclose. And like we just talked about, optineurin is a gene associated with familial normal tension glaucoma. And it involves IOP independent neurodegeneration of the visual pathway that progresses with ages. And at the same time, we are not clear how optineurin actually plays a role in normal tension glaucoma. So we wanted to understand this mechanistic aspects by actually knocking out the optineurin in our animal models. We generated an optineurin knockout model, which is homozygous, and the hypothesis in this study is that the loss of function mechanism may induce structural and functional eye deterioration with aging. So we monitor these animals over ages. We use multiple assessments, including looking to eye anatomy, the visual function, eye pressure, and also retinal histology. In terms of the brief results, consistent with the role of optineurin with normal tension glaucoma, we don't really see any eye pressure changes in the knockout mice at both young and also aged durations. And you could also see there's no apparent differences in the gross anatomy in the eye. In terms of the surface of the eyeball, there's no dispersion of the pigments, the iris, and also the ciliary body trabecular meshes looks generally fine. If you look into the retinal layers, they also seem to be relatively grossly intact. Quantitatively, we have noticed that the young optineurin knockout mice may have thinner retina in the peripheral regions, but in the young ages only. In terms of the thinning over age, we observe there's actually similar extent in the central retina during aging. This seems to be primarily related to the thinner ganglion cell inner plexiform layers, but not the other layers. And in terms of visual function, we look into the optomotor response, and it appears that there are some small decrease in the visual acuity in the wild type animals from young to age, but we don't see there's a big decrease in the visual acuity as shown in the left side. The contrast sensitivity also tend to be increased. That means they're getting worse from young age to old age. But the extent also seems to be a little smaller in our optineurin knockout mice. Finally, when looking at different cell subtypes, we examined the bipolar cells, retinal, horizontal cells, and even the photoreceptors, microglia, astrocytes. They seem to be unaffected in the optic-neuron deleted animals. But interestingly, we observed that there's actually more dopaminergic emicron cells in our age optic-neuron mice when compared to the age healthy control mice, meaning there may be relatively preserved emicron cells that are dopaminergic during aging. So in conclusion, our findings show that when we completely lock out the optic-neuron, which is essential for a lot of functions like mitochondrial energetics, exon transport, etc., it actually just result in relatively mild retinal changes and also relatively small visual function impairment. This kind of support the possibility that optic-neuron-associated glaucoma may not result from a loss of function disease mechanisms. So we are now looking into the alternative pathways, such as if there is any toxic gain of functions, or if there's other detailed molecular pathways involved in normal tension glaucoma, and if there's any other factors beyond genetics, like clinical or environmental factors that can be targeted for glaucoma treatment. With that, again, I would like to thank our laboratories in New York University and also Duke University, and also the funding support. Thank you very much.
Great, thank you, Kevin. That was a great presentation. Any questions from the audience? I have a question. How did you measure the contrast sensitivity in the mice?
Oh yeah, so there is a device called optometry, and it's actually basically it's virtual reality device with four monitors, and the animals can stand on a stool, and they can be awake, and just interestingly, when we present the different rotating bars, they will be attracted to them. And we can change the frequencies of these rotating bars. We can also change the contrast. So frequency would correspond to visual acuity. Contrast sensitivity would be how grayish those bars are. And as the animals are awake and attentive, we'll be able to change the frequency and the contrast, and we'll find the best responding point for both of the acuity and contrast sensitivity.
But you didn't find any significant difference between the optic-neuron and the knockouts vis-a-vis the wild types?
Right. Interestingly, there's actually more deterioration in the wild type during aging in the visual acuity, and in the contrast sensitivity, there's little difference in between the optic-neuron knockout and in contrast with the mild type. So our hypothesis is maybe the optic-neuron knockout is not as harmful as we expected. Maybe there is something even because the optic-neuron is totally gone in our knockout mice. So something may be compensating when optic-neuron is gone. What is the exact mechanism? We have to look into it further. Could it be even protective? That's an even more bolder hypothesis to look into.
Thank you. Thank you so much. We go on to the next talk.
Yep. Well, first of all, we want to know if Dr. Yun He Son is here, because we don't have the PowerPoint uploaded, so we wonder if he may have any computers available for plug-in. If not, then I will come to the last speaker. Right? That's Dr. Surya Suhakaran. Yep, she's here. And the topic is 2-year outcomes of selective tunnelnectomy versus mitomycin C during RMAT FP7 tube shunt implantation.
All right. Hi. I think this is the last session of the entire Congress. Thank you for the opportunity, APAO. So we did a 2-year study comparing selective T-nonectomy versus mitomycin C during AHMED FP7 tube shunt implantation at Stanford. Okay, one second. So we know that bleb fibrosis and tenon encapsulation are the most common cause of surgical failure during trabeculectomy or glaucoma tube shunt surgery. And we have two potential solutions for that. One is we can either do a T-nonectomy, or we can do antimetabolites like mitomycin C and 5-fluorouracil during the surgery. These methods usually blunt the hypertensive phase, after placing the implants. But then no one has looked into the long-term outcomes of the differences between these two processes. So the hypertensive phase is usually defined as an IOP more than 21 within the first 3 to 6 months of surgery because of the fibrous tenons and tissue over the implant and inflammation and congestion. So we usually use aqueous suppressants like beta blockers, carbonic anhydrase inhibitors to reduce this hypertensive phase. So to modify the process and to prevent fibrosis, we can use intraoperative mitomycin or selective tenonectomy before the conjunctival closure, or you can do postoperative 5-fluorouracil. So they looked at, a lot of studies looked at, randomized control trials with 12-month follow-up and compared MMC for 5 minutes versus BSS, and they found no significant difference in operative success. IOP at any point, number of meds or complications were similar, but few have found out that when they didn't use the MMC, then there was a risk of hypertensive phases eventually. So we had a comparative case series with 90 patients, 90 eyes who underwent AMED FP7 implantation, and that was done by 2 surgeons between 2017 and 2024. Inclusion criteria was more than 18 years, all types of glaucoma, and pre-op IOP of more than 18 despite MMT, maximum therapy, and more than 3 months of post-op follow-up. And we defined failure as IOP of less than 5 or IOP of more than 21 or not, reduced by 20% from baseline after 3 months. And another definition of failure was when you needed a reoperation for glaucoma or loss of perception of light. So this is the follow-up at the start. 41 MMC, 49 tenonectomy. Obviously, it was by different surgeons. That's one of the flaws of our study. And at the end of 2 years, we had 22 mitomycin patients and 34 tenonectomy for evaluation. So this table is describing the baseline characteristics of the 2 groups, which was not statistically significant in any way. And except for the only thing was IOP had like a mild 0.06, which was not significant. And on various postoperative time points in mitomycin C versus tenonectomy groups, you can see the graph is almost together. The lines are together, so there was no difference in the IOP at various time points. Okay. So this is the table showing the IOP change and number of medicines at various time points. So first is we can see that it's the antifibrotic group and the tenonectomy groups. And the significance in difference is noted by the p-values. So you can see that 0.06 was the statistical significance, so it was not that significant in IOP change or baseline IOP, or at 1 year outcome, there was a slight difference, which showed that it was 0.045, statistical difference. And at 2 years, there was no difference between the antifibrotic group and the tenonectomy group. So initially, when we had the data for the first year, that was in the first group, there was no difference. But as we followed up for the next 2 years, then the statistical significance slightly started becoming more evident, but then still it was not significant enough to conclude that there was a difference. So there was no difference in number of glaucoma medications in both the groups too. And there was no changes, there was no changes between the 2 groups in terms of visual acuity. Even number of medications needed at various time points were similar. And both groups were started at around 4 medicines on an average, and post-operatively decreased to approximately 2 medications, and they remain fairly stable with a slow uptrend. And then we looked at the failure rates between the two groups over the 2-year course, and there was no difference. So majority of failures were due to additionally glaucoma surgery needed or insufficient IOP lowering. That's what we defined it as. So when we looked at the failure rates between the two groups over the 2-year course, there was no difference between the two groups. And complication rates between the two groups over the 2-year course, there was no difference. So the mean IOP, maximum IOP, visual acuity, failure rates, complications, and medication use were similar between the eyes treated with MMC and selective tenonectomy. So similar safety profile and failure rate. And even though baseline IOP tended to be towards higher in the MMC group, with resulting significant difference in IOP changes at 3 and 1 year, eventually MMC did not impact the IOP during the hypertensive phase, after the tube implantation, or at the end of 2 years. So our limitations were that ours was a retrospective design, and it's a small sample size, and there could be a possible differences in patient baseline characteristics, like baseline IOPs, what kind of glaucoma. We didn't look into what kind of glaucoma it was in the first place. So we cannot, like, it's mostly secondary glaucoma, so we cannot generalize it into, POAG. So it's almost always based upon what kind of etiology it was in the first place. And another thing is that each technique was performed by one surgeon. So tenonectomy group was by one surgeon, and antifibrotic was by another surgeon. So surgical techniques, the differences in surgical techniques also could have influenced the outcome.
Time is up. Yeah, maybe we can go to the discussion. The time is up.
Okay. So my conclusion is...
Could you show the second last slide again?
Yeah, you can.
The second last slide again. Another, usse pehle wala. Okay, the slide before that.
This one?
Yeah, so I was just wondering, the mitomycin application, did you, just before this, the slide before
Right.
this, did you do a one-time application of mitomycin, or was it multiple injections that you gave these patients?
No, mitomycin was just one time, intraoperative.
So you write mitomycin did not impact the IOP during the hypertensive phase after the tube shunt.
No, that means that in cases with mitomycin that was given in the initial surgery, the hypertensive phase was not impacted. So it's not about mitomycin being given as another time. It's just talking about the first cases in which mitomycin C was given, and then what happened to the hypertensive phase later on.
So how many patients actually had a hypertensive phase?
I can say that. I think around 17% had a hypertensive phase in the first three months to 1 year. 17.
What percentage?
17% had a
1/7.
Yes, 1/7.
And then, so how did you decide whether they were failures or success? Like
Depending upon the IOP, like we classified it as less than 5 or more than 21 at every stage. Like, and then final outcome was only measured at 2 years. So whether it was more than 20, number of medications more than 4.
So once the hypertensive phase happens with an AGV, it's very difficult sometimes to control it.
Yeah.
So, but your IOP, when you showed your IOP reductions, the mean reductions are actually very spectacular. I mean, they're not showing any failures, and they're actually not showing how many patients had a high IOP. So I really
In the
don't-
hypertensive
yeah,
phase?
yeah.
Yeah.
I mean, how high did it go and for how long?
Okay, so we haven't looked into
Okay.
that in detail
Yeah.
much.
And in one of your discussion slides, I think you mentioned that the baseline IOP for the MMC groups tend to be at least slightly higher with a p 0.06.
Yeah,
And at the same
0.06.
time, you also mentioned at 3 months, there's a significant difference in the IOP changes. This is based on the absolute difference in IOP, right? Yeah. Because we know there's a potential difference in the IOP baseline. How about the relative changes, the rate of changes? Do they seem to show also
From the
difference?
initial to, I think there was no difference between the two groups when they did the relative difference too. And the reductions were almost similar.
All right. We do have time.
So
Any more questions?
Yeah. Mm-hmm. No. It was just exclusively MMC. No. This was just like to
Yeah.
Mm-hmm. Without, right? Yeah.
Yeah. Yes.
Or tenonectomy.
Yeah.
You're not using tenonectomy either. Okay.
Yeah.
That's a good suggestion, actually. We should do a third wing too.
Okay.
Yeah.
Thank you.
All right, thank you.
Hopefully this was
thanks
helpful.
to
Thank you.
everybody. Thank you for all the speakers and my co-chair. And yeah, it has been a good session. Thanks to all. Okay.
Thank you,
good.
Dr.
Thank you.
Gupta. Yeah.
Yeah.
And I think the organizers would like the speakers to come over to take a group photo. Right. Yeah. So if you are still around, please come over. Thank you for coming. Have a good rest of the day.